Good afternoon, everyone. I'm Janice Whitaker, CGNE Administrator and Education Program Manager. It's a pleasure to serve as host of the CGNE Seminar Series. I'd like to introduce and thank Jenny Rank, CGNE Education Program Specialist, for all of her assistance in implementing the seminars, and Amy Caputo for developing our marketing for the series. This program is being provided by the Teresa Neese and Helen Diskovich Center of Geriatric Nursing Excellence at the Penn State Ross and Carol Neese College of Nursing in collaboration with the Office of Outreach and Professional Development, the Center for Nursing Research, and Age-Friendly Care Pennsylvania. Today's seminar, Enhancing Care for Older Adults Living in Corrections, will be presented by Dr. Erin Kitt-Lewis, Associate Research Professor and CGNE Associate Director of Education at Penn State Neese College of Nursing. Before we begin the presentation, we do have some disclosures and announcements. Penn State Ross and Carol Neese College of Nursing is approved with distinction as a provider of nursing continuing professional development by Pennsylvania State Nurses Association, an accredited approver by the American Nurses Credentialing Centers Commission and Accreditation. Participants with a valid RN license who attend the entire nursing continuing professional development program can earn 1 contact hour. Partial contact hours are not awarded. The topic of this education is non-clinical, and therefore we did not identify, mitigate, or disclose relevant financial relationships. Just to make participants aware, we are recording the seminar. If you have a comment or question for our speaker, please put that into the chat feature at the bottom or top of your screen, depending on your format. You can also raise your hand using the raise hand feature, and Jenny will watch for that and unmute you so you can speak aloud to share your comments or ask your questions. The post-event evaluation link will pop up in your browser when the webinar concludes. It will also be emailed to you within 24 hours. So for RNs, as well as everyone, we do encourage everyone to complete the evaluation, but it is required for RNs seeking contact hours. So again, we'll end the seminar a couple minutes before 1 o'clock so that you can take a few moments to complete the evaluation that will pop up in the browser, or you can do it when it's convenient for you, either later today or when it's emailed to you tomorrow. But it does have to be done within a week of the seminar, and then you will receive your certificate within a month of the seminar. If you have any questions or concerns, you can always reach out to cgne@psu.edu. So next, I'd like to introduce Jenny Connect Frito, one of our graduate student affiliates that recently received the CGNE PhD Student Champion Award at our Alumni and Friends brunch this past Sunday. So we were thrilled to recognize Jenny's outstanding contributions to our center's mission, and we appreciate her introducing our speaker today.
Thanks, Janice. So Dr. Erin Kitt-Lewis is an associate research professor at the Penn State Ross and Carol Neese College of Nursing, and associate director of education for the Teresa Neese and Helen Diskovich Center for Geriatric Nursing Excellence. Erin's research focuses on developing and testing evidence-based educational models and facilitating learning experiences for people who provide care to those who are older, have chronic conditions, or at the end of life. More specifically, she has collaborated on several projects that develop training for people who work in or live in corrections to enhance the care for people living in prison. In addition to her research, Kitt-Lewis has 20 years of clinical experience in end-of-life care for patients and their families in multiple care settings. Welcome, Erin.
Thanks, Jenny. Great, I'm going to go ahead and share my slides now. Can everybody see them okay?
Yes.
All All right. So as Jenny said, I'm Erin Kitt-Lewis, and I'm here to talk to you about older adults living in corrections. By the time this seminar is over, I hope that you're able to understand the complex and growing healthcare needs of people who live in prison, recognize opportunities to support the people who live and work in prison to care for older, chronically ill and dying individuals, and then also explain the process of developing educational modules and resources to help educate the people who live or work in prison. So I'm going to try to open my chat here so I can see everybody. But I just wanted to ask you a question. What do you consider, or when do you consider someone to be an older adult? What age would you say? If you just want to put that in the chat. And while you're doing that, I just put very famous people who have aged, appear to have aged very well. And a lot of these faces will be familiar with you. Right, so we're seeing 65, 70, 75, 80. Yeah, so the NIH usually considers somebody 65 or older, this is generally speaking, to be an older adult. However, we all know that, you know, different groups define older adult different ways. So how do we define an older adult living in corrections? An older adult usually is anyone over the age of 50 years. And the reason this is living in correctional facilities shortens life expectancy and it hastens physiological aging. Also, aging coupled with living in prison increases the probability of experiencing health problems such as more chronic conditions, more comorbidities. Health status of people who are 50 years or older is the equivalent of someone living in the general community that are about 10 to 15 years older than that. So a person that's 50 would compare to someone 60 or 65 living in a community setting. So how many older adults live in prison? A lot. Older adults are the fastest growing segment of the population. From 1991 to 2021, the percentage of the state and the federal prison population for people that are aged 55 and older increased from 3 to 16% in male prisons and to 10% in women's prisons. Older people comprise 5 times the US prison population as they did 3 decades ago. The other problem is that many of the people in prison are serving life sentences. So even if they're not an older adult today, likely they will age and die in prison because they have a life sentence or some version of which amounts to be a life sentence. So in 2020, 30% of people serving life sentences were 55 years or older, which is more than 61,000 people. While there are efforts focused on compassionate release or medical parole, this is really unlikely in the current climate. There is a lot of advocacy out there to get people released sooner, earlier, but they've really not made any headway to date. The other issue is a lot of the people, like I said before, people living in prison have a lot of comorbidities, chronic conditions, and so the needs that they'll face while they're in prison will only increase. Okay, and in addition to this, there's been a lot of sentencing changes in laws around sentencing and parole both that both create longer sentences and mandatory minimums. So I'm not sure if you're familiar with all of these, but most people have heard of the 3 strikes law, came around in the 80s, but it mandates these extremely long sentences for individuals convicted of 3 felonies. This could be 3 drug offenses, nonviolent crime even, but if you get arrested for the 3rd time, you're in life without parole. Truth sentencing, or which is where the person is required for people to serve 80% of their sentence in prison before becoming parole eligible. They also had some laws, I think they're starting to change them again, where this was like an early the 90s, 16 states abolished parole, but they're starting to come back with some parole eligibility new laws in those states. They also are reducing the time allowed to be released for good conduct. And then I'm sure you've all heard of the tough on crime laws of the 80s as well, which created longer sentencing. The other interesting fact, which many people aren't aware of, are there's been a lot of changes in the arrests for people, and people 55 years or older account for a greater share of the arrests. So not only are people, coming into the prison systems or correctional system at young ages and aging in the system, they're also coming into the system as an older adult. And you can see where the arrests changed from 2% in 1991 to 8% in 2021 of the people being arrested were 55 years or older. So how much does this cost to provide care? State and federal government spend more and more money on consistently inadequate health care. One example, I just looked at California. They're spending 3 times as much money to incarcerate an older person than any other age group. And if you think about this, the proportion of the California prison population that are over the age of 50 has risen from 4% in 94 to now nearly 25% in 2019. So now 25% of the prison population is costing the state 3 times as much money to keep them housed and providing the needs that they need. Federal prison, I couldn't find any recent statistics for the federal prison. The most recent one I could find was from 2013. And it's the Federal Bureau of Prisons. They spent 19% of their total budget, and the 19% is the $881 million. So they spent $881 million to incarcerate older adults. And the other interesting feature that I don't spend time talking about in this presentation, but I do want to mention is there are statistics for prisons are really difficult to get. Not each state keeps the same records. And so sharing information and trying to build like a global picture around this concern can be quite challenging. And at a recent conference I was at, we talked to some people that help manage the data, and they were trying to figure out better ways to capture and report data to help inform us and allow to build research projects around this to really meet the needs of those who are living in prison, and also the correctional facilities that need to house them, and try to troubleshoot best practices and ways to essentially provide better care for less dollars. So how is the health of an older adult prisoner or person living in prison? They experience stress-induced accelerated aging, which I mentioned before. So a person in the community, they are approximately 10 to 15 years older in terms of their health. They frequently have chronic or life-limiting illnesses that require intensive management. And when compared to their community dwelling counterparts, people living in prison are more likely to experience falls, incontinence, difficulties with ADLs, hearing impairment, and multiple concurrent illnesses. So if you look at the CDC's, oh my gosh, I just lost the word. That's terrible. This is my post-COVID brain. Social determinants of health. There, I just got it back. When you look at the social determinants of health, many of the people who are incarcerated, are not necessarily well educated. Some don't have high school diplomas, but they are able to obtain GEDs while they're in prison. Some do have advanced degrees, but not many. Their healthcare prior to prison was poor. Their higher prevalence of substance use, and other risk-taking behaviors that have an effect on their health. Their neighborhood and built environment aren't always, the best situations. And same way with their socioeconomic status prior to entering prison. So if you factor all this in, it just compounds the problem for their health once they get into prison. So what kind of healthcare services are available? In theory, they can receive any healthcare that they would like. It just takes time to get referrals, but it is available in theory. But many of them do receive inadequate healthcare and poor symptom management, and there's a lot of factors that play into that. The first one is correctional facilities are not healthcare facilities, and so they have a motto, it's care, custody, and control, but custody and control always take precedence over care. So there's situations when they don't let people living in prison get maybe the care that they need because they prioritize the custody and control over that. They have limited access to clinicians, especially those with geriatric expertise. It's also very expensive. I looked at the average copays across the country for state prisons, and they average $2 to $5 per visit, which that doesn't seem like a lot of money. And just so you know, Pennsylvania is $5 per visit, but they're only allowed to voice one complaint per visit. So you can't, if you have multiple symptoms, it could all be related to, let's say heart failure. They could have swelling, they could, have a headache from high blood pressure, they, maybe shortness of breath. They're only allowed to offer one complaint per visit until they are diagnosed with a chronic condition and then get put into the chronic care clinics. So if you think of a visit being, even at the $2, the lower end of the range, they only make on average 14 to 63 cents per hour. So if you're trying to make a $2 copay on 14 cents an hour, you might be working, 14 hours to cover that. If you're making the higher end, you're working anywhere basically from 14 to 35 hours to pay for a visit, depending on that cost. Now, if you do have a diagnosis of a chronic condition, you are able to get into the chronic care clinics. And so, you get some symptom management, education, as well as routine visits scheduled for when your medication needs renewed, and they'll give you a supply with every visit. Sometimes there's not access to the physicians, and so they don't get to make their chronic care visit, but they still do continue to reorder their meds. And so there's a lot of issues around that as well. They're not really being assessed, but the medications will continue. So another reason why people living in prison don't access care is because they have a fear. They don't, not in every case, but there is an overarching theme of not trusting medical staff. They're also afraid of being diagnosed with something that will remove them from their current either housing or work setting. So let's say you have a diagnosis of, dementia or cancer. You might get released from your job, moved from your housing unit, or even moved from that prison and moved to another prison. And so if you have been living in prison for 30 plus years, and this is the only family that or friends that you're now going to a completely new environment, and you really don't have any say over that. So a lot of people won't report or speak up when they do have symptoms, and they'll just wait till they, can't do it anymore. And, they're really close to the end. And they'll get, a diagnosis of a stage 4 cancer, or their symptoms will be so poorly managed that, they don't have a choice but to seek medical help at that point. Another factor is the lack of dental health needs. And this can include things from regular cleanings to dentures, and it can also lead to pain and inadequate nutrition. And if anybody joined the ECHO series that CGNE and the College of Nursing put on related to dental health, we've learned a lot through that. And this is another population that this really does affect. The dietary circumstances in prison, it's a very institutionalized menu. So think back to your worst school lunches. Everything comes from a can pretty much. There's a lack of fresh fruits and vegetables. And so, there's a lot of sodium and preservatives in the foods that they eat. Some staff do question prisoners' motives or attitudes around seeking medical attention. So they might see them as trying to, complain of pain just to seek some kind of narcotic. And so therefore pain medication is pretty restricted, especially narcotics in prison. Also, cognitive impairments may come across as being non-compliant or difficult. And so they might get, the person living in prison with a cognitive impairment might get reprimanded because they're not able to respond to commands that corrections officers give them. Like, for instance, standing count every day, or showing up to a place at the time and, being able to stand there and wait until it's their turn, because they lack the ability to do that. So here's just another graphic that I pulled for older people in state prisons. And if you compare their chronic conditions at the age of 55, it hits these types of statistics, the equivalent of these statistics, like for instance, hypertension. 62% of the population doesn't have hypertension in the community setting until they're closer to 70. And this is happening at 55. So 65, 70 is the average, where it's happening for people who are incarcerated when they're 55. So what are some concerns that you can see for older adults in prison? And if you just want to type in the chat, and while you're doing that, I'm just going to call your attention. This is a typical cell that two people would be sharing in prison. They have a bottom and a top bunk. If you're assigned these, so if let's say you're a top bunk and you start to decline as you age, and you need a bottom bunk, you might get moved out of your cell. So the cellmate that you lived with for many, many years, you no longer can live with. You could be assigned with someone that, you maybe not get along with, just to get that bottom bunk designation. The other issue is there's so many people now with bottom bunk designations in the correction settings, especially in Pennsylvania, that they really are running short on the bottom bunk. So that might get you moved to a new prison, and you're taken out of this prison. And if you just look at some of the seating, the little stool in the back, or the toilet, it's not handicapped accessible. There's nothing to grab hold of when you're sitting down or trying to stand up. And so there's lots of concerns there. The other issue is, depending on the facility, I haven't been in every prison, but I've been in many. Just to walk to get your meals, it might be the equivalent of 2, maybe 3 blocks. And if it's, the dead of winter in Pennsylvania and there's snow on the ground, that can be a challenge. The same way with Medline or your medications, you might have to walk across the campus to get your medications. So it's not necessarily that everything is in the same building across the hall. or even down the hall, or even inside. There's also lots of issues with lack of heating and cooling. So there's many prisons in Texas that don't have air conditioning. So imagine, you know, the temperature is 102 and you're living in a cement block building with no air conditioning and you have COPD. So there's just lots of factors that you need to consider. And then the other thing is, you know, all the statistics that I just shared with you, people that are in corrections, living in corrections, are older and sicker than they were 30 years ago. So when these prisons were designed, and some of the buildings are very, very old, you know, they were not designed for older adults. They were designed for young people, as you can see with, you know, the bunk beds and the toilets. So. Okay, sorry, that's freezing. Let me see if I can get this to advance. Perfect. So other concerns that you may not see just by looking at that picture or letting me paint this picture for you. I mentioned the standing count, and if they're not able to stand count at 11 o'clock, or they don't even know it's 11 o'clock because maybe they have a cognitive impairment, they might be disciplined for that. I said walking to Medline, walking to Chow Hall. Commissary items, so let's say that you aren't able to eat what they're serving in the chow hall or the main dining room. You might want to buy some commissary items. So I looked up, you know, I've been looking up commissary items because we do education on this and we wanted to make it as realistic as possible. But things you can get in commissary are soups, which are laden with sodium, canned meats, candy bars, which are high calorie, low nutrition, chips and chip-like snacks, a lot of sodium, preservatives, soda and drink mixes. But the products that almost every state and the Federal Bureau of Prisons specifically say on when you look up their commissary items, products that can quickly spoil cannot be purchased. And they list things like fresh fruit, fresh vegetables, which is exactly, you know, what would be a healthy option. So part of our education that we added was finding the best choices that they could pick in commissary, things like maybe nuts, although there's still a lot of sodium in there. But, you know, if you're going to get the ramen noodle package of soup to make, don't use the seasoning or half the seasoning. So we have lots of tips and tricks to try to help manage that, but not a really healthy option. So that's sort of I'll pause here just to see if anybody has any questions about.
Erin, I just wanted to point out that there were many participants that put some concerns in the chat.
Thank you. Thank you. I just am now seeing that. So yeah.
Yeah.
So living with dementia is a really big concern. In fact, it's such a concern that Susan and I have a project right now where we're trying to create educational modules to train not only the staff, but people, we call them peer caregivers. So people living in prison who can help their fellow peers who have dementia, and just do some education around what dementia is, that it isn't really non-compliance, that it is a cognitive impairment, and, you know, maybe creating an environment that is more conducive. Yeah, the end of life, that's another one. That's my area that I really am focused on, but thinking about things like advanced care planning and just symptom management at the end of life. You know, if narcotics are hard to get, and perhaps people dying alone, because if you're at the end of life, they'll take you from your cell block and put you in the infirmary, and you're often not allowed any visitors while you're in the infirmary. So it's the only contact you have is with staff if there's not a peer caregiver involved, and some facilities do have that now. Yeah, safety, there's a lot of vulnerability for people who live in prison. You know, people will take advantage, especially if they know you have a cognitive impairment. And we've written in some things, and I'll show you those later, into some of our educational models, kind of scenarios for the peer caregivers to think about what would be taking advantage. And we'll kind of get into more of that. Let me see what else. yeah, decreased access to care and resources is a big thing. And the other thing is, some of the resources that are available in the library, you know, that can be a challenge to get to. So if people are interested in their learning more about their chronic condition like COPD or heart failure, they'll go to the library and try to look it up, or they'll call somebody that's living on the outside of prison to try to get information from. But it is a real challenge to get that. And if you're not able to kind of understand that information or read, you know, some of the medical or nursing documents related to your chronic condition, it can even be more of a challenge to get that information. So yes, people living in prison are allowed to have mobility devices, such as walkers or wheelchairs. But again, that can change your living status. And it also, if you have a wheelchair, you might need support. So you'll have to have some kind of peer support specialist, perhaps help with your transportation, or you might get moved to the infirmary. Let's see, who have maintenance meds, who monitors. So if you have a chronic condition and you're on maintenance meds for any reason, you are supposed to be seen, I believe it's every 90 days, and then they reorder your medications, but there's not always enough availability to be seen by a physician or a mid-level provider to reorder those and kind of reassess you. So what we're finding, or what we're hearing from some of the participants in our study, is they'll just reorder the meds without having a visit. So the assessment piece is missing. So do they need their Lasix increased? Is this particular medication working for their blood pressure? That doesn't always happen, that follow-up. So, and again, there's a lot of mistrust from the people living in prison with the medical staff. And so, you know, they aren't always adherent with the regime. Okay, so I'm going to go ahead and move on, and then we can kind of ask some questions at the end here. But what can we do, or what have we done? And I think this is my 6th project, but the first thing I'll say is, you know, being part of a great team and great support system is really beneficial. So a lot of you might recognize Dr. Susan Loeb. She's been a PI on most of the projects, or a co-I on, I think, all of the prison studies that I've worked on. Janice Penrod was retired faculty from Penn State, and she was the one that kind of brought me into my first prison research experience. Catherine Aiken is an undergraduate student in biobehavioral health. She's in the bottom left-hand corner of the screen, and she's worked with us, I think, for the last 5 years. And she's, you know, been a great co-researcher in our endeavors, and she'll graduate with her master's in May. And then Sharif, I'm sure most of you know him. He is a doctoral student who will graduate in August, and he's been with us, I think, for 4 years, I believe. I have a picture of Barb from Klein Bundle. She is our research partner. She works for a small business in Boulder, Colorado, and that is how we get our small business grants from the NIH to conduct this type of research and build these educational modules. And the last person in the bottom right-hand corner is Bree Williams, who I was funded as part of the Arch Network. And she supports research for older adults in corrections. And she funded, which was my first project as a PI. And so I'm really appreciative of my team. And there's others that have helped us along the way, or, you know, collaborated with us, including Megan McGraw. If any of you know her, she's still working in the College of Nursing. Oops. So the evolution of our program of research, I started in this line, as I said. Janice Penrod asked me to be part of I call it the original prison study, but it was called Infusing End-of-Life Care into Complex Organizations. And through this, we used participatory action research with 74 staff who work in a correctional facility, and we used the state of Pennsylvania. And we developed paper pencil modules. So we actually had copies that we put in boxes, and we created a resource library of books and helpful information. And if we were doing that today, we would have Ann Kolanowski's book in there. But we were so proud of this project, but we soon realized that it was very bulky. It ended up sitting in either the educator's office. Not everybody had access to the resources. We also used the PDSA model for quality improvement to help spark interest in getting new programs started. And we even had information on how to train peer caregivers to help or assist with end-of-life care. And although the 6 prisons that we worked with, were very interested and did have some uptake in there, broad dissemination didn't really work because, it involved creating a flash drive, which is sometimes hard to get into the prison systems. And so you'd have to have these photocopies and sent. Anyway, we decided that computerizing this, making these electronic educational models would be more easier to disseminate broadly. And so that launched us to the next project, which we called ECADP, Enhancing Care. Enhancing care of the aged and dying in prison. And this was 2 phases. So the first phase, we developed 3 educational modules. And when I look back at our original modules, which was in this project, we had PowerPoint pictures we were putting on slides and trying, it was very, very new to us. We had a lot to learn. We've gotten much, much better at the process, but trying to conceptualize how these were going to be transformed into an electronic version was, anew, and we weren't really sure what the vision would end up being. And so even from phase 1, where we developed the 3, and we picked these 3 modules based on our advisory board feedback, focus groups for both people living in prison and the staff, created these modules. And then for this phase 2, we refined them. And you can even see how our logo changed from phase 1 to phase 2. People said the hands needed to look more real. They didn't like the coloring of the logo. So that, we kept refining. And then for phase 2, we created 6 modules to help train people who work in prison, care for the older adults and dying people. And then the next phase, Susan and Barb, who you saw on the slide previous, who are PIs, wrote a grant for the e-training of inmate peer caregivers for enhancing geriatric and end-of-life care. And just to show you some of the advances that we made, we decided to call this Inmates Care. This was based off of, again, focus groups, advisory board, feedback, and even with the logo and the pictures, this is what in round phase 1, people decided we should call this. And then we realized that inmates can be is stigmatizing. And so in the next phase 2, we changed it to, again, based on advisory board feedback and focus groups for people who live in prison, to Just Care. And our logo kind of, again, changed to more realistic hands. And so in the Just Care program, initially, we created 3 modules, again, based on what the peer caregivers thought was important that they needed to be trained in to really understand how to take care of people who are, aging and dying in prison. And also we had to be aware of how the different prison policies. And so some of our training would be very specific. And then some we would say, if your policy allows you to do direct care, then you can do this. If your, facility doesn't have a policy that allows direct care, you'll need to follow your facility's policy and, you won't be able to participate in this piece of it. We didn't quite word it like that, but it had to be very flexible. So different prisons, administration would be willing and interested in using it, because if something would go against policy, like especially the direct care, this would be things like bathing, grooming, dressing. Some facilities do not allow a peer to do that to another peer in any role. So that is the evolution. So just to kind of recap, the original toolkit did have training for both staff and peer caregivers, but paper pencil. ECAD-P was for staff, and then Just Care is for peer caregivers. And I'll talk a little bit more about Just Care to kind of give you an idea of what all goes into this. So again, this is an SBIR funded project, and any kind of small business grant from NIH, you have to be you have to be a small business, can't be a university. So Klein Bundle is the one, in collaboration with Susan, wrote for this grant, and they are actually the ones that hold the grant, and we are subcontracted through them. I mentioned that the name evolved over time, and we really paid a lot of attention to the logo and how we branded it, because the participants, the people living and working in prison, thought that was very important. We wanted them to own it and have a voice in it and feel comfortable with it. And again, I said, like, we changed the language. We were inmates care, enhancing care through the aged and dying. We called it ECAD-P for a little bit. And then we finally landed on Just Care. And again, during the phase 1, we developed these 3 prototypical modules. Again, worked on graphics, trying to find the right images, which was another challenge. There's not a lot of great photos or images that reflect what a prison really looks like, and especially someone older and maybe dying in prison, or the care that's being provided to them. And so we did have to do some photo shots in our lab, in our nursing simulation lab in the ground floor at University Park campus. We also did a video. If anybody knows Darlene Clark, she did some hand washing videos, a huddle video with her giving report to a peer caregiver. And, we just incorporated all these pieces into this, and we just kept refining it. And as we got feedback from our advisory board, and just to give you some context on that, that was people who worked in prison, some at high levels, some in nursing, people who were formerly incarcerated, and some experts in end-of-life geriatric care. So nurses and physicians that worked in that area, either in or outside of prison. We also had focus groups, that kind of helped us refine that as well. And then we did at each phase, we would have usability testing. And so we would show them what we created, ask them their thoughts and feelings on it, and then get feedback and then make adjustments. And I'm just going to flip through these, but this is what our Just Care modules look like. And so once you completed it, so where it says course introduction, it's done. So it gets dark blue. And then the one that you're actively working on is pink. And then here are our modules. And they also have a module for staff. So if the staff wanted to do any supplemental education, they can see what we're training them. And if they wanted to provide some like hands-on or real-time training with them, maybe around some direct care work, they would have that opportunity to see what they're doing and support that. And again, these modules are just serving as, an enhancement. We recognize that training needs to be ongoing, but you can see our table of contents and all of our modules. Here are some images of different pieces of the module. So this is talking about what they can do to support emotional and social needs, some hands-on duties they may be able to provide. Here is one of our graphic novels. So this is getting at the notion that we can't take advantage of the patients. And this person, there's, I think, 6 slides in total for this graphic novel that the person would flip through, but I gave you the first and the last. But the patient says, I'd like a pudding cup, peanut butter cup, noodle soups, and lotions. And she tells her peer caregiver, pick up anything you'd like for yourself. And, throughout the other slides, the peer caregiver's thinking about it. And the patient at the last one says, you didn't get yourself anything. She says, I really appreciate your offer, but I can't accept gifts from my patients, even if they are small items. And so just kind of role modeling what's expected of a peer caregiver. This activity is looking at infection control and all the high touch places that you can spread germs. And so in the actual activity, there's red dots on areas of high touch, and it tells you, why this is a place that you need to clean regularly, or it's a high touch area. And, if you're sharing, like, for instance, the wheelchair, if you're sharing that between people, this is what needs to be done before it's shared. And they click on that red dot and it gives them more information. Here's an image of oral care. And then this is Darlene practicing putting on PPE, and she did all of the PPE for us and a hand washing video as well as a huddle video. The other, and I know we're getting short on time, but the other educational module that we're currently working on is Just Care Dementia. We're in a phase 1 for that. So just creating the initial 3 modules. We've did our focus groups, completed them, and the 3 areas that the participants think we should focus on are promoting safe and calm environment, behavioral and psychological symptoms for dementia, and heightening awareness around dementia. And there was 2 others that came up, but these are the 3 we're going to focus in on for round 1. We've created the modules. They're being programmed. Actually, they just finished programming these, and we have the IRB. We're working on the IRB, getting it approved. We're going back and forth to go in and do some usability testing for this. So I don't have any screenshots of these particular modules, but here is the logo that was selected to represent the Just Care for Dementia. And then the last project that I want to talk about is end-of-life care planning and corrections. So this was my first opportunity to be a principal investigator. And I did 2 studies when I was originally funded by ARCH, as I mentioned. And the purpose was to determine essential components to include for a toolkit for end of life. And I'd like to turn this into educational modules as well, and just have it be a module that, correctional facilities can use to kind of help walk them through the process for both the staff and the people who live in prison. And, I got awarded this in 2020 when COVID hit, and they weren't allowing any research in prison. So what I ended up doing is, for this one, I interviewed returning citizens, people who are formerly incarcerated, and we got some great information. It's the first time I used Zoom to interview participants, and it worked really well, and I gained a lot, and it helped me refine, to do the next study, which the Center for Nursing Research funded, and I was actually able to go in prisons and interview people who live in prison. But the results from this first round talked a lot about, there's just a lack of general understanding around advanced care planning. They said that we need to really talk about what essential features need to go into this, and the timing of the conversation, and some of the potential barriers. And one of the potential barriers was this idea of risk versus benefit. And I put this quote in because I thought it was really powerful. And this was a woman who was in a facility, formerly in a facility. And she said that, we don't want to seek care, or we don't want to think about it, because in her situation, to seek care, it was about a 3-hour bus trip. We would have to stay at another facility overnight, which is horrid and terrible, terrible, terrible place to be, and another 3 hours to the hospital. The stripping, the searching, not having water and air conditioning is a miserable, miserable trip. And women would avoid it for that. Like, I don't want to lose my bed, because if they'd be diagnosed with something, they might not go back to the prison that they came from. I don't know if I'll come back to this unit. It's a miserable trip to get down there to the hospital and to be in and out, like you get dismissed. Healthcare at prison hospitals is better than the unit, obviously, but basically she was saying, I'm not going to go. I don't even want to know what's wrong with me because, you know, I could lose my housing. I could not be in that facility anymore. And then the whole trip when you're not feeling well isn't comfortable. So. And so, as I mentioned, the Center for Nursing Research funded me for my next project, which I was able to actually interview and do focus groups in a men's prison and a women's prison. And we were able to do in person. We weren't able to audio record, which was a little bit of a challenge, but we learned about the different components of what they thought should go into advanced care planning. And the name to them was really important. And they really thought, I always thought we should call it like end of life care planning because it made sense to me. It seemed very easy, but they thought it should be called advanced care planning. And, you know, they provided some reasons. They also said we need to normalize the conversation. Most likely, many of them are going to die in there. They know that. They just don't always want to talk about it, but, you know, we need to start talking about it early so we can get more people on board to make their needs and wants known as they age and die. Some of the content was chronic conditions, emotional support, community, and legal services. And then when to have that initial conversation, they thought should be an admission, diagnosis. The conversation should happen annually, and it didn't really matter what discipline provided the information, but it had to be the right kind of person. So someone who had compassion, someone that was knowledgeable and seemed to be interested in them and having this advanced care planning done. And then here were just some barriers. It was a taboo subject. They feared and wishes wouldn't be honored even if they would mention them. And then some of the facilitators, they wanted consistency. There was training. It's called, the initials are, or the acronym's PREA, but it's Prison Rape Elimination Act. And this training happens annually, and they're very familiar with it. It's done in this very consistent way. Someone comes in, you have to do it. It's mandatory for every person living in prison. And they said that structure and flow, because they knew what was coming, they knew what to expect, was comforting, and people took it seriously. And so they said, if you could do something that mimics the way PREA training is done, it would be helpful. And the other thing that we learned just by having the focus groups, we got this feedback. Any conversation that makes an inroad to a problem that has existed for many years is positive. And just by participating in the focus groups, many of them said we learned something new today. And they did learn stuff from each other just through word of mouth that was happening in the prison related to advanced care planning. So now what? We're going to focus on just care, and we're working on large scale usability testing now. Just care dementia, we're working on small scale usability with those 3 initial modules. And I'm trying to write in my spare time an R21 to hopefully that will get funded, and I can do some more work towards this advanced care planning and getting it turned into e-learning modules. And then there's always room for things related to chronic conditions, dementia, and neurocognitive care units. And I think I'm over time, so I'm gonna now ask for questions. Sorry, guys, I went a little bit over.
No worries, Erin. Thank you so much on behalf of our CGNE leadership team, as well as all the participants here today. Thank you so much for an amazing presentation. I know you really enlightened me. I thought I had a general sense as to healthcare for older adults in the correctional setting, but you really provided many insights and data and information to really examine the breadth and depth of some of the issues. So thank you for sharing all of that. We do have a couple of questions that were in the chat earlier, so I think we should start with those. Kimberly Strife is asking, would they mix schizophrenia, so people living with schizophrenia, with the general population in the correctional setting?
They do have mental health housing units, and they're very restricted. They actually call them restricted housing units. So they would, if they would have some kind of mental health diagnosis where, you know, they would act out or hurt somebody, they would be in a different housing unit, much more restrictive, less opportunities to intermingle, and sometimes no opportunities to intermingle. But yeah, so they would be separate.
Yeah, probably based on their risk of harm to either themselves or other people, right?
Yeah, and they, I think they are overcautious. So people might spend many days isolated alone
Mm.
before they would risk exposing somebody else to, you know, injury.
And Light is asking, are there any collaborative efforts with external healthcare providers or community resources to improve healthcare outcomes for older adults in corrections?
So it's interesting that you say that. We've just we're a physician in a local hospital reached out to us because they receive a lot of people who are incarcerated who are at the end of life, maybe are coming and having a surgery and being diagnosed with a terminal condition. And, you know, they're trying to figure out who's going to make their decisions for them if they're not able to. And what happens is when the prison or correctional facility tries to find their point of contact, it might be a sister that they listed as their point of contact when they were in their 20s. And now the sister may have dementia, passed away, isn't at the same number. And so trying to get a hold of their next of kin or their decision maker is a real challenge. And so these physicians in these community hospitals are struggling, not knowing what to do. And so that's why we're trying to work on this advanced care planning to, you know, help get get a recent contact on the books or look at it every year. Is this person still able to be their power of attorney or decision maker if they would need one, and not someone that was listed? You know, some of these people that are incarcerated in their 80s, you know, they were incarcerated when they were in their teens. They weren't even adults, some of them. And so their family has aged as well. And yeah, so yeah, we are working. We need
So
to
it sounds like they may not have kind of a system in place to kind of update that information routinely so that, you know, they've got more up-to-date contact information.
yeah.
I wanted to ask you, Erin, that you have certainly put so much effort and expertise into developing this educational programming. And I love the fact that you used focus groups too, to gain insights and input into the process of the curriculum development. That is really amazing. I'm wondering about dissemination. You know, do all correctional facilities throughout Pennsylvania, for example, have access to these modules? You know, who can use them at this point?
So right now, nobody, because we're not to that phase yet. But
Okay.
there are, you know, they are a commercialized product. So there might be a very, very small fee. I know the people that you know have own the intellectual property don't need to get rich off of this, or that's not their intention, but there does need to be some kind of cost to upkeep it, but we're not there yet. And you know, that's to be determined. And hopefully there's a lot of interest, I will say that, but we're just not there yet.
There's a couple of other great questions in the chat, but because it's 1 minute to 1 o'clock, I'm afraid we're going to have to end there. And certainly folks can reach out to us at cgne.psu.edu. And we can maybe try to, Jenny will put the email in the chat. But if you want to reach out with a question, we can relay it to Erin. And just again, thank you to everyone for coming. Thank you, Erin, for this amazing presentation and sharing all of your expertise with us. When Jenny ends the session, please know that the evaluation should pop up in your browser. You can complete it then, or you can complete it when it comes to you via email within the next 24 hours. And Erin, there's all kinds of, I hope you're seeing all these wonderful, positive responses and comments related to your presentation. So thank you so much.
Thanks, everybody.
Have a great rest of your day, everyone.